This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2020, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is diaphragm protective ventilation. Thomas Pareno is a registered respiratory therapist working as the clinical specialist, mechanical ventilation, for the Center of Excellence in Mechanical Ventilation at St. Michael's Hospital in Toronto, Ontario. Thomas discloses he has relationships with Draeger and Fisher & Paykel. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability.
My name is Thomas Pareno, and I'm going to speak to you about diaphragm protective ventilation. The objectives of this presentation are to describe the mechanisms of diaphragm injury that can occur during mechanical ventilation. I'm going to discuss different monitoring options for measuring diaphragm function in the intensive care unit. I'm then going to describe concepts of diaphragm protective ventilation, and then describe the potential challenges of the balancing between diaphragm and lung protective strategies. I'm going to discuss these potential mechanisms of diaphragm injury: excessive support, giving your patients too much help or fully controlling their ventilation within the ICU and what mechanisms of injury can occur with that; insufficient support, essentially making your patient work too hard; using excessive levels of PEEP. This is a new concept, a hypothetical concept of does giving patients too much PEEP actually change the fiber structures of the diaphragm. And then patient ventilator asynchrony. I'm going to discuss different mechanisms of injury that can occur with different types of patient ventilator asynchrony. The possible mechanisms of injury I'm going to discuss are excessive support. If you give your patients too much support, it's going to, of course, cause atrophy. That's one of the mechanisms. Insufficient support, making your patient work too hard. This will potentially cause diaphragm injury. Excessive levels of PEEP. Now, this is a new concept demonstrated in animal models, and we don't know for sure if it's being caused in humans, but it's something to consider, and I'll discuss this mechanism. And of course, patient ventilator asynchrony. There's a number of different types of asynchrony that activate the diaphragm at different times, and this, of course, could lead to different types of diaphragm injury. So let's start with atrophy-induced injury from excessive support or fully controlling the patient. Let's first talk about excessive support. This is a classic paper by Levine and colleagues demonstrating that cases which were brain-dead patients with no diaphragm activity experienced diaphragm atrophy within 18 to 69 hours. Now, it is important to note that there are many studies showing that even over support with pressure support can cause this diaphragm atrophy to occur, but this is a classic paper demonstrating how severe this mechanism and how fast it can happen in humans. 18 to 69 hours, there was a chemical process put into place that caused proteolysis that accounted for fiber atrophy in both slow and fast twitch fibers. So this is, again, very classic, highly cited paper demonstrating how quickly it can happen in humans. The diaphragm becomes atrophied. And if you think about this concept, which muscles never intend to stop? The heart and the diaphragm. We don't stop breathing for any reason. So then there's load-induced injury. Now, the atrophy is quite simple to understand. If you don't let the diaphragm work, it's going to stop working. But this concentric loading or this load-induced injury, this is making your patients work too hard. And I'm going to spend more time on this because this is where we really have to think about protecting the diaphragm when it's being used. So increased respiratory drive, patients have a very, very high drive. There are a number of things in the literature that discuss potentials for injury. First off, there's a high work of breathing when patients are working too hard. This is the reason why they get placed on a mechanical ventilator, because they can't continue to work this hard. We need to support and help them to breathe. So there's an oxygen cost of breathing. Muscles use oxygen and patients will use more oxygen, so there is a cost. But then there's this load-induced injury, which isn't just this oxygenation problem, but possibly hemodynamic instability. There are many papers citing that breathing can actually improve hemodynamic stability, but it can also impact it in a negative way. Then there's diaphragm tissue injury, which I will discuss as well. But pulmonary edema and regional lung strain, these are elements of lung protective ventilation, or terms that we use with lung protective ventilation that also are linked to the activity of the diaphragm. So let's first talk about these two things. First, there is evidence to suggest that in patients that have extremely high resistive load, so tight airways, a lot of resistance, and they're making huge negative inspiratory drive, negative pressures in the pleural space can lead to this negative pressure-induced pulmonary edema. So they generate this pulmonary edema on their own. And in this cascade in the top right, you can see this mechanism that occurs that when someone gets lung injury, they get capillary leaking, you get lung edema already, and then you have impaired gas exchange, which results into increased respiratory drive. And this increased respiratory drive causes or can lead to something that's been termed patient self-inflicted lung injury. Self-inflicted lung injury. We are used to hearing the term ventilator-induced lung injury, but now we're thinking in concepts of, can the patient actually worsen their lung injury? And this is the concept of patient self-inflicted lung injury that, again, would not be possible without activity from the diaphragm. So it's this contrast now where we want the diaphragm to work, but if it works too much, it may actually lead to further lung injury. So this is a difficult task for us as clinicians to monitor at the bedside and try to find a solution to balance this. And then there's regional lung strain that can occur. This is a classic paper by Takeshi Yoshida demonstrating with electrical impedance tomography that patients with high inspiratory drive can actually pull volume. And if you look in this graph, the red box is showing the ventral regions of the lung. And if the patient takes a strong effort, you can see that the impedance waveform, which should be going up during inspiration, is actually going down from the ventral regions and going up in the dorsal regions. This means that although you see the tidal volume going in from the ventilator to the patient is pulling more than we anticipate into the dorsal regions, which might be good for recruiting the lung, but can also cause lung strain and potential further self-inflicted lung injury. Now, with oxygenation and hemodynamics, I mentioned that there's some benefits. Spontaneous breathing has been shown to improve oxygenation because it recruits dorsal lung atelectasis, it reduces shunt, improves ventilation and perfusion matching, improved ventilation to the dependent regions of the lung. These are all examples of why we've been told that spontaneous breathing is important for patients. And it can enhance hemodynamic performance because you have a rise in abdominal pressure and a fall in pleural pressures, which increases venous return. Excellent. However, when spontaneous breathing is excessive, muscles consume oxygen, and if you already have impaired gas exchange, you don't want the body to be using more oxygen than it's able to obtain. So it can reduce oxygen delivery to other critical organs because the muscles are using it all, in fact, the diaphragm muscle. So spontaneous breathing can worsen hemodynamic performance as well by increasing cardiac afterload, and it can cause and lead to acute left ventricular failure. And this is a classic paper by Laurent Bouchard in 1989 showing this cost of breathing that I mentioned earlier, where increased excessive work of breathing can consume more oxygen. And as you can see, as the work goes along on the x-axis, you can see the cost of breathing. This is the consumption of oxygen increases and goes up. So there's been demonstration that diaphragm tissue injury can occur even in healthy controls. So in this study, you can see they have non-loaded, so meaning they haven't caused an increased load to the patient's diaphragm in terms of their breathing. There's this level of injury that doesn't exist, and then they give this inspiratory load to these controls, and you can see that it's clearly rising, hasn't quite reached statistical significance, but in someone with a healthy diaphragm, you can start to increase this potential for injury. What they found is interesting in that even in patients with COPD, because they have chronic lung conditions and different mechanisms for breathing and different work of breathing, they already have demonstrated, compared to healthy controls, that they have, again, diaphragm injury related fiber mechanisms in the sarcomeres. They can see that there's some injury related to the muscle fibers. And of course, increasing that patient's workload significantly increases their evidence of diaphragm injury that is occurring. So this is the main reason why when patients come in and they're in an exacerbation of COPD, for example, we need to offload work of breathing and help them to lower that work of breathing, because with that increased load increases their diaphragm tissue and fiber injury. Now, this is a classic paper by Dr. Ewan Gallagher out of Toronto demonstrating that they measured the diaphragm thickness with ultrasound in patients and found this interesting trajectory that for patients where the thickness of the diaphragm measured on day 1 and over time, you can see up until day 8 of the study, patients that did not change their diaphragm thickness, so the change was less than 10%, it wasn't significant to them, they found that those patients are the green line going across, and there were patients that the diaphragm thickness decreased very rapidly and over time, and then there's patients that it increased. And they're not quite sure the mechanisms of why it increased, or again, whether it's edema, et cetera. But what it tended to demonstrate are there are patients that have excessive work, patients that have no work, and patients that maintain a comfortable and normal level of work over time. And of course, the patients that had less than 10% change in thickness were off the ventilator faster. And the patients where it had a decrease in thickness, they were on the ventilators longer, and the ones that had an increase in thickness also were on a ventilator longer. And the diagram on the right-hand side, I recommend looking up this paper and reading the paper and then trying to understand this diagram. It's one that is shown in many slides when we talk about Dr. Gallagher's slides, but it's complex and it looks really pretty. But basically it demonstrates the relationship between the diaphragm contraction activity, which is the thickening fraction of the diaphragm, duration of ventilation, and the thickness of the diaphragm and how they interplay. Now, PEEP-induced injury, this is a new concept. This is muscle fiber remodeling. This has been demonstrated in animal models, but we're not quite sure if the extent of this is happening in humans. However, it's definitely a concept that needs to be further studied and paid attention to. And what they demonstrated, or at least hypothesized prior to their study, is they know that PEEP, when you increase PEEP, it actually pushes the diaphragm down. And this is well known that it can shift the diaphragm. Now, it increases lung volume when you increase PEEP, and it can flatten out the diaphragm dome. And muscle fibers are now at a shorter length because they're closer together. And I'll show you a graphic that helps demonstrate this. But at that shorter fiber length, what happens is the diaphragm then begins to remodel to be more comfortable at that level. And then this can become a problem when you then reduce the PEEP, because now you have less muscle fibers there to help with work of breathing. So first off, they demonstrated that when you increase PEEP or decrease PEEP, it does in fact shift the diaphragm. And this was done in rats. They just demonstrated that going from a PEEP of 0 up to 3, the diaphragm is shifted. And then you can see above, you can see PEEPs of 12 down to 2, diaphragm shifts. So we know that the diaphragm moves as we adjust PEEP because it changes lung volume. Okay, so what does this mean? If you look at the top graph here, at normal end expiration, we have a specific muscle fiber length, and it's demonstrating the sarcomere length there as well. When you increase PEEP and you shift the diaphragm down, you shorten the muscle length. So now the sarcomeres are very close together, and what happens is the long-term effect of keeping PEEP at that level is it says, you know what? I'm not very long anymore. I don't need as many sarcomeres, so it remodels the diaphragm, and now you see there are 2 lengths there for sarcomeres rather than the 3 that were there before. But then when you reduce PEEP, and this is typical of doing a weaning trial where you reduce PEEP to have patients work more harder, see if you can get them off the ventilator, these patients then fail. And patients may be failing due to diaphragm dysfunction, and this dysfunction could possibly be partly from this mechanism if you had them on elevated or excessive PEEP that was unnecessary for too long. Because as you can see, now that the muscle length stretches out, it doesn't have as many fibers to support the contractility of that muscle fiber. And what they found is that they used not only the muscle fibers from the animal models, but in humans, in controls and in critically ill patients, they took fibers to see if we stretch out these fibers, how does the contractility work? And they found that it didn't matter if you were a healthy control or a critically ill patient. Once you get beyond a certain muscle fiber length or sarcomere length, you have an inability to contract properly. You have diaphragm dysfunction. So now let's go on to load-induced injury, but rather than concentric contraction, and I didn't explain it clearly, but concentric contraction is the type of contraction we expect. You know, when you do a bicep curl or you're doing a crunch, again, you are contracting the diaphragm, that's concentric loading. Eccentric loading is a little bit different. It's essentially contracting of the muscle when it's supposed to be lengthening. So, in relation to diaphragm injury, let's be very clear. During inspiration, the diaphragm goes down, and during expiration, lung volume empties and the diaphragm is repositioned back to baseline. So in mechanical ventilation, when patients are being assisted, they may contract the diaphragm, or maybe the ventilator pushes it mostly, if it's doing most of the work, it pushes it down, and then as the ventilator releases the pressure to return back to baseline, as it goes down, if the patient then inspires, they're contracting when the diaphragm's supposed to be lengthening. And it's increased work at not an ideal time. So this is eccentric loading, and this can happen in a number of different types of patient ventilator asynchronies. So the most classic example is ineffective efforts. Many clinicians are able to recognize the ineffective efforts that occur when patients make an inspiratory effort but cannot or do not trigger the ventilator. And as you can see in this diagram, every time where you see the arrows, the patient is making an effort that is not registered or supported by the ventilator. And of course, it's occurring during exhalation. So lung volume is reducing, the diaphragm is going back up as the patient exhales, and they're making an effort that's unsupported. It's just this eccentric work. Okay, so that's one of the mechanisms. Another one is short cycling, and this happens, there's two types of conditions where you may have the patient inspiring after the ventilator cycles off. The first one is short cycling, patient triggered, meaning the patient initiated the breath and the machine stopped delivering the support to the patient while they were still inspiring. So as soon as the machine stops delivering the help, it enters that passive expiratory phase where the lung volume starts to decrease, but the diaphragm is still contracting, and now it's an eccentric contraction. Okay? And of course, there's also this mechanism of reverse triggering, where the machine delivers the breath, which then triggers the patient to make this inspiratory effort. It's sort of a reflexive action as you're watching it at the bedside. The machine gives a breath that wasn't triggered by the patient, but then the patient makes this effort, and of course the machine has preset criteria for when it stops the breath. So if it stops the breath and the patient's in mid-inspiratory effort, this is, again, an eccentric contraction because the lung volume is emptying and the patient is still inspiring and holding that contraction. So how can we take all these concepts of potential mechanisms of injury and how do we monitor inspiratory effort at the bedside? So I'm going to talk about different technologies and techniques that can be used to monitor diaphragm function at the bedside. These are the technologies I am going to discuss. Esophageal pressure swings, because some ventilators now are including esophageal pressure as an option to have on your ventilator screen. And there's other ways, other tools, bedside monitors that can do it separately. There's electrical activity of the diaphragm, which requires a specific catheter. There's PMUS, which can be deducted by using modes, for example, like PAV+. There's diaphragm ultrasound, which I've already mentioned the work by Dr. Ewan Gallagher, and I'll talk about the technique for measuring diaphragm thickness and thickening fraction. There's the occlusion pressure, the classic occlusion pressure, which is the P0.1 maneuver, which every classic ventilator and every new ventilator has as an option to measure inspiratory effort, and I'll describe this and what the target values are. And then there's this new concept, this different type of occlusion pressure that is an expiratory pause for a one-breath maneuver, which was literally just published this year, 2019. And this is a new concept, and I'll talk about that, and I'll end with that presentation of that study, as well as an online tool that can be used to help to see the impact of both the diaphragm and the lung protection and how they could possibly work together or how they sometimes conflict. So the technologies and techniques I will not discuss just because they are complicated techniques that aren't typically done at the bedside because they're mostly done in research. They involve different types of catheters. They involve measurements while the patient's passive and then after they start to breathe. And this is the pressure time product and the transdiaphragmatic pressure. Again, two very common techniques for monitoring inspiratory effort in research, but hasn't translated to routine practice at the bedside, whereas all of these techniques, I think, can be utilized at the bedside very easily by any day clinicians, and I think that's why I'm going to focus on that, and I'm going to skip over this stuff. So esophageal pressure, you insert a catheter, it sits in the lower third of the esophagus, and it monitors changes in esophageal pressure. So in the passive patient who's not breathing, every time the ventilator gives a breath, the esophageal pressure goes up. It's a surrogate, so it represents pleural pressure. So it's a surrogate for pleural pressure because we're not going to poke holes in people's lungs and measure their pleural pressure. So every time the machine gives a breath, the pressure goes up. But when patients make an inspiratory effort, of course, you inspire, your pleural pressure decreases. So your esophageal pressure decreases when there's inspiratory effort. So the swing in esophageal pressure has been used in a few studies to sort of look and see, can we predict failing of a spontaneous breathing trial or readiness for a spontaneous breathing trial? Now, if you just look at the swing in the first minute of applying no help from the ventilator during a spontaneous breathing trial, it doesn't have the best predictability. But in this study by Diaphragm and colleagues in 2005, they actually took the swing in esophageal pressure in the first minute and then compared it to the swing in the esophageal pressure in the 9th minute and have this algorithm for determining what they call the PES trend index. And it actually was better than our typical rapid shallow breathing index that we do every day to determine the readiness for a spontaneous breathing trial. Interestingly enough, it has not taken off into routine clinical practice, likely because the use of esophageal pressure was not common practice, so it just hasn't been picked up for many clinicians to use at the bedside. But the opportunity is there that now the ventilators have this esophageal pressure, it could be programmed to actually determine, you tell the machine that you've started a spontaneous breathing trial, it then measures the swing after 1 minute and after 9 minutes of the spontaneous breathing trial, plugs the numbers into an algorithm and tells you or predicts their success for weaning. And I think this is an opportunity for industry to step up and say, okay, we've agreed to put esophageal pressure on our ventilators. Maybe we can go back and look at these studies, again, published 14 years ago, and say maybe we can utilize this as a better predictor of success for mechanical ventilation liberation. So these are the tests we do to see if the patient can come off the ventilator. Now, other studies have just looked at the swing, and it does appear that an esophageal swing more than 15 centimeters of water, so you start exceeding that, you're getting closer to 20 centimeters of water, these patients typically will fail a spontaneous breathing trial. Why that's important is that if you haven't even started a spontaneous breathing trial and you're wondering if your patient is, again, having too much effort, this load-induced concentric contraction, are they working too hard? If the patient is receiving assistance from the ventilator and you see a swing of negative 20 centimeters of water, you are under-assisting that patient. And you can forget the idea of trying to get them off right away because they're currently working way too hard and they likely will not be able to maintain that, specifically if you take the breathing tube out. So you should increase the support to try to reduce that drive. Now, again, another use of esophageal pressure is this dynamic transpulmonary pressure. So this takes the increase in pressure delivered by the ventilator during, for example, pressure support ventilation, and then it takes the drop in pressure in the esophageal tracing, and when you take those two values and add them together, you get what's called the dynamic transpulmonary pressure. So again, you can determine whether or not your patient has a high dynamic transpulmonary pressure. And in the literature, the cutoff values for what they consider high dynamic transpulmonary pressure is about 15 centimeters of water. So when it starts to exceed that, this becomes excessive inspiratory effort by the patient. Now, there's a large interplay between the ventilator settings and the diaphragm, as I've mentioned, and of course this can impact the lung and can potentially cause lung injury, but of course all of this is driven by the brain. So very smart clinicians, Dr. Christer Sinderby out of Toronto, St. Michael's Hospital and the Li Ka-shing Institute, they developed years ago this concept of what if we could take the signal from the brain, it's the electrical activity of the diaphragm, and what if we could have triggering of the ventilator, cycling off of the ventilator, all based on this electrical signal. So this is where the mode NAVA was born. Having said that, EDI is also a very, very useful tool for monitoring inspiratory effort in your patients and ventilator asynchrony. Even if you don't want to use the NAVA mode, you could monitor how well they synchronize with any mode at all. So it takes the electrical activity, it does represent the neural signal reaching the diaphragm from the brain, and in most patients, a change in response to increasing and decreasing inspiratory load, your EDI signal correlates with that effort. So if you increase support, the EDI should come down. If you decrease support, it should come up. If you're weaning the patient, you want to see that trend stabilize, or if it's continuing to rise, you know your patient's working harder and harder and harder, and again, it may lead to failure of your spontaneous breathing trial. So With this concept of electrical activity, it's important to understand that we need to know what normal values are. And with the electrical activity of the diaphragm, typically clinically relevant numbers include numbers such as 3 to 5 microvolts of electrical activity. You start to get to a point where it makes sense the diaphragm is doing some meaningful activity. We've looked at many tracings over the years, and if your EDI signal is 1 or 2, it's a very weak effort, probably not clinically relevant. And if your goal is to get the patient breathing spontaneous, it might be that they're still on support with opioids or with sedatives. So you probably want to start reducing that if you want to increase that drive. Once you get to a level of an EDI signal, a microvolt level of between 8 and 10 microvolts, that's when it becomes very ideal situation to, if you wanted to use the NAVA mode, you would switch them to that mode. And then a normal value for EDI is a range between 5 and 15 for most patients. If they have chronic injuries, chronic lung conditions, or chronic diaphragm injury, it may be much higher. But for most standard patients, 5 to 15 is an acceptable range for EDI. Another way to estimate inspiratory effort is by measuring PMUS using a mode PAV+. You can measure PMUS with catheter placement, etc., but the mode PAV+ automatically calculates compliance and resistance and uses that to put into the equation of motion. And for breathing is basically taking the elastic load that is required to breathe and the resistive load, and these two things together create the total work required to breathe. And the muscular pressure generated by the patient is the PMUS. Now, when we place a patient on a ventilator, the ventilator shares some of the total work. So now the work is partly from the ventilator, partly from the patient to overcome the elastic and resistive loads. Now, with PAV+, you set a percent that you want the ventilator to do. Okay, so I'm going to give you a clinical example. I don't want to get too deep into proportional assist ventilation because it's not the purpose of this talk. However, if you are understanding and using proportional assist ventilation, particularly PAV+, this mode, then this is something that applies. There's a quick clinical example. If my peak pressure is 22 centimeters of water and my PEEP is 10, the delta pressure being provided to the patient by the proportional assist mode or the PAV+ mode is 12 centimeters of water. If my PAV+ percent support is set at 50%, I know that that delta pressure being delivered by the ventilator is 50% of the total work. Therefore, the patient is doing 12 centimeters of water of muscular pressure or work by them. So now I know that they're doing 12. What's an acceptable range? There's a paper by Carteau and colleagues that targeted 5 to 10 as an acceptable range, and we're currently using this range to target PAV+ in a large randomized control trial currently underway in 2019, comparing PAV+ with pressure support ventilation. And this is how we are titrating PAV+ in these patients to target a comfortable range of 5 to 10 centimeters of water of PMUS. Now, you can calculate it for all types of levels. So 50%, as I mentioned, you're matching the patients of 50 to 50. It's a shared ratio. So whatever the ventilator is doing, in this example, 12 centimeters of water, the patient's doing 12 centimeters of water. If 12 was on the screen and your patient's percent support was set at 65%, and I've specifically chosen these PAV levels because they increase the gain or the amplification factor, typically by 1 until you get into the higher levels. But going from 50 to 65, so a jump of 15%, changes the gain factor by 1, meaning the ventilator is doing 2 times the work when you go to 65. If you go then up 10% from 65 to 75%, the ventilator is now doing 3 times the work as the patient. At 80%, the ventilator is doing 4 times the work of the patient. So as you can see, as you go higher, you have to make smaller changes to make that large impact in terms of work of breathing overtaken by the ventilator. So it's important that if you went from 50 to 55% on PAV+, you may not actually be assisting a whole lot more. Jumping from 50 to 65 will change that amplification factor by 1. You're now assisting the ventilator 2 times as much as the work the patient's doing. Now, back to my example. At 12 centimeters of water that the ventilator's doing, if my setting was 65, I know that my patient is doing half of that because the ventilator's doing 2 times more than my patient. So what's my patient doing? 6 centimeters of water. 6 times 2 is 12. At 75%, I know that it's doing 3 times the work of my patient. So if 12 is still the number at 75%, my patient's doing 4 centimeters of water of work, or PMUS. So that number is a little bit low. So if I had my patient at 75% support and I measured the PMUS and it was 4 centimeters of water, I would reduce my PAV plus support to try to get them into that target range of 5 to 10. Now, if you want this to be sort of simplified, you can Google PMUS calculator and you will find a calculator that can do this. If you just do a Google search for Medtronic is the company that makes this calculator and makes the ventilator that has PAV Plus as a mode. If you type it in and you type in PMUS calculator Medtronic, you will find this page where you just input the values that I just mentioned, 22 of peak pressure, PEEP of 10, and then you can see at every percent level, you can see what the work of breathing by the patient would be. So you know the delta pressure by the ventilator, and then you just look and see what percent support you have them at, and as you can see, 50% is 12 in this example, so you would probably increase the support to get them down into a lower level. Now, that POC calculator online that I just demonstrated, I actually have added it to a more full calculator that I developed myself, and it's free to use, it's online, it's not sponsored by anybody, it's just I like to program and I like to create interesting calculators to help, again, demonstrate concepts. I have this calculator at rtmaven.com. If you go to this site, you're going to see that there's also the diaphragm thickening fraction, which I just mentioned. There's the occlusion pressure, the estimating of PMUS and dynamic transpulmonary pressure, as well as other tools for measuring recruitability of the lung and using esophageal pressure measurements to determine transpulmonary pressure. And so I'm going to demonstrate now for you at least the two concepts that I just discussed with diaphragm thickening fraction and the occlusion pressure, how the calculator works, and demonstrate that for you in real time right now. So once you get to rtmaven.com, you'll see there's a menu at the top. There's respiratory mechanics, airway opening pressure, and recruitability. And in fact, that one has videos at the end of the web page. So if you're going to do or play around with any of these, please watch the videos at the end of this for that second one, airway opening pressure and recruitability. Let's look at the diaphragm thickening fraction first. So if you we're going to click on that. And then, as you can see, it gives a little bit of instructions for assessing the maximum thickening fraction, which I mentioned earlier is providing no help from the ventilator. But let's assume your patient's breathing on the ventilator and you just want to measure the typical thickening fraction. So let's throw a couple of numbers in here. Let's say the thickness at end expiration is 2.3. And then at end inspiration, it increases in thickness to 2.6. Let's hit calculate. And you can see the diaphragm thickening fraction is 13%. So if you recall, this is on the lower end of the acceptable range that we would typically try to target between 15 and 30. So we may be over-assisting this patient, or they may have diaphragm dysfunction. So how do we determine if it's just over-assistance or actual diaphragm dysfunction? So if it's over-assistance, I can try to manipulate the ventilator and see if it increases into an acceptable range. If it does not, I may do this maneuver, this maximum thickening fraction, where I remove the help from the ventilator and redo the measurement. Now, if that's what I had just done, we can click that this was a maximum effort, and just by doing this little checkbox here, it then changes the instructions or the suggestion of what this might mean. It says this indicates that the patient has diaphragm dysfunction because it should be more than 20%. Now, I will give the caveat that these calculators online are designed for teaching, education, simulation, playing around, understanding the concepts. Taking this and applying it at the bedside is at your own discretion. You should understand what you're doing clinically. They are just tools to understand the concepts. I know clinically people that are using this calculator. However, it's at your own discretion. I don't want any responsibilities for you using this tool. Now, that's one way to use it for the diaphragm thickening fraction. Let's move on to the next one, which is predicting high inspiratory effort. Again, recently published 2019 information. It's on this calculator online, and let's put a couple of values in here to see how we can predict the PMUS and the dynamic transpulmonary pressure in a patient. So let's say my patient's on pressure support 5 and 8. So my first number is going to be 13. So let's say the peak pressure is reaching 13, my PEEP is 8. And then that's my during tidal breathing. So I'm just observing the ventilator. I see my peak pressure is going to 13 and 8. Okay, fair enough. Now I do an expiratory hold on the ventilator, and then I look at that change in pressure. I go back and I look at my values. My baseline pressure is 8 centimeters of water, which was the same as my PEEP. If someone had total PEEP, it might be slightly higher, but in this example, it's 8. and then the inspiratory effort they're making goes down to -4. Actually, let's make it a really excessive effort. Let's go to -8. This is a significant drop in pressure here. We calculate this, we can see that not only is it a high PMUS, which could be potentially injurious for the diaphragm, but it's also an elevated dynamic transpulmonary pressure or transpulmonary driving pressure. And again, both of these values indicate that it's probably not good for both the diaphragm or the lung. Okay, so let's increase the support to the patient. So the first value, we're going to go up to 16 centimeters of water. So I've increased it a bit, and let's say it was nice, the patient felt a little bit more assistance, and they lowered their drive. So the last number there, instead of being -8, it's now 0. Let's hit calculate. You can see now how giving the patient a little bit of support, if they respond and reduce their drive, they now get into a range that is considered more safe. We have a PMUS that's between 5 and 10, and we have a dynamic transpulmonary driving pressure that is now less than 15. It's not at that 16, 17 range where we might start thinking about doing something. This is a patient who seems to be in the range of diaphragm and lung protective ventilation. Now, diaphragm ultrasound, as I mentioned, it's a growing interest specifically with our group out of Toronto, Canada, and worldwide there's getting a lot of hype in terms of understanding the diaphragm function at the bedside, and ultrasound is a way to visually assess your diaphragm. So I've mentioned a number of tools to measure inspiratory effort, but here's an example of actually visualizing the diaphragm to see what it's doing and if it's contracting properly. So you'd put a patient in the semi-recumbent position, head of bed 30 to 45 degrees. You take a high-frequency ultrasound probe, you start at the mid-axillary line between the 9th and 10th intercostal space, and you can use a vertical or oblique approach. All that does is if you use a vertical approach, you're likely going to see 2 ribs in your image. And if you turn the probe more oblique, you basically go in between the intercostal space or in the intercostal space, and you miss those ribs. So it's just a way of getting rid of the rib in your visual view. And then stabilizing the probe is probably one of the most important things once you've identified the diaphragm, because the patient is constantly breathing and ultrasound gel is quite slippery. So if you're not anchoring that probe properly, it's likely going to move and it's going to affect the quality of your image. The zone of apposition is right at the side of the patient. So the diaphragm goes, yes, across your chest wall, but it then curves and goes right along the side of your chest. And so I put the diagram sideways because if anyone hasn't looked at an ultrasound image before, what happens is when you apply the probe to the side of the chest, you have to understand that the diaphragm is not going perpendicular from you because you're in the zone of apposition where it becomes parallel with the side of the chest wall. So when you apply the probe, so that ultrasound image, if the probe was at the top, you are looking down and then you are seeing the pleural membrane and the peritoneal membrane. And this is important for understanding what you're looking at. And that's what you're trying to find is that zone of apposition. It's the zone at which the diaphragm becomes parallel with the chest wall. Once you find it, you can adjust your cursor and you can see there's the M mode capture point. It's a dotted line on many ultrasound machines. You want to make sure that it is crossing a point where you can see visually that those membranes are quite clear. And then what happens is when you switch to a mode called M mode, it takes that slice, that exact point that you point your cursor at, those dotted lines, and it just measures that point over time. And of course, those 2 thick membranes you see move during inspiration and expiration. And then you measure those thickness points. You can see the one on the left is a much larger. This is during inspiration, the muscle thickens. As the diaphragm goes down, the muscle thickens, and this increases in thickness. And then during exhalation, it goes back down again, and the next breath goes back up again. You take those inspiratory and expiratory levels and you do what's called the diaphragm thickening fraction. So you take the peak inspiratory thickness minus the end expiratory thickness and divide that all by the end expiratory thickness, and you get essentially the change in thickness that occurs during inspiration. Why do we want to measure this? As you can see in this work, again by Dr. Yu and Gallagher, you can see that the range between 15 and 30%, those patients had the lowest or the least time on the ventilator. And as I mentioned before, patients who are working very little, so on the left side of the screen are patients with a very low thickening fraction, so the diaphragm is not thickening very much during inspiration. They have very low inspiratory effort. It could be because they're heavily sedated, they're still critically ill, but those patients end up being on the ventilator longer, However, on the opposite side, you have patients with excessive thickening. So they are, again, the thickening fraction, I should say not the thickness, but the thickening fraction is higher than that sweet spot, and those patients are also on the ventilator longer. So patients with an increased thickening fraction are working harder and probably working too hard, which then leads to them being on the ventilator longer and having difficulties weaning. So that sweet spot of a target where you want patients to be at is between 15 and 30%. Now, this concept of actually adjusting the ventilator according to this has not been tested yet. This is just showing you the correlation or the association between thickness and time on the ventilator. However, whether or not trying to measure that every day and adjust your ventilator to maintain that range, whether or not that gets patients off ventilators faster or it in fact protects the diaphragm still needs to be tested in a proper trial. Now, I mentioned the normal range 15 to 30. Lower means insufficient effort and higher means excessive effort. So just keeping those concepts in mind that they haven't been tested yet, but this is conceptualizing the idea of how could we utilize diaphragm ultrasound to target ventilation. This is one of the proposed mechanisms that we could do that. Now, there's another measurement called the maximum thickening fraction. This is to assess or determine severe diaphragm dysfunction. So to do this test, you take away all the help from the machine. So they have to be either off the ventilator on a T-piece or just dialing everything down to 0 of support and 0 of PEEP. And then you do the same measurement I just described, this thickening fraction, but during a maximum inspiratory effort. So you instruct the patient, please take the deepest breath you can, and you watch that breath, and then you again capture that image, and you're already recording in M mode, as I mentioned. You capture the image, you do your measurements, you determine whether or not the thickening fraction changed, the thickness from expiration to inspiration, again, plugging into that equation whether or not the thickening fraction was more than 20%, or 20% or higher. If it's less than 20%, this demonstrates severe diaphragm dysfunction. Okay? Now, some patients, when you try to instruct them to take a deep breath, they don't take a deep breath for you. Okay? So consciously, they're not quite aware enough to actually participate in this effort. So what can you do to address that issue? You can do an expiratory hold on the ventilator and watch that their inspiratory effort is increasing. Now, it sounds a little bit barbaric, but these are tests that are done to typically determine inspiratory effort in patients and the strength of inspiratory effort. So it's a common test where you occlude the ventilator and it's a negative inspiratory force that you're measuring. But as it increases, it gets to the point where you then release, and they should have a maximum inspiratory effort that you then are capturing with the ultrasound and doing your measurements. So if patients don't participate or don't follow commands, that's one way to actually get that measurement. Now, P0.1, I mentioned the occlusion pressure. This is the drop in pressure in the first 100 milliseconds of a breath. Every ventilator on the market has this ability to measure this value. Some ventilators measure it or estimate it in real time, so it kind of deducts or predicts what it might be after the patient triggers the ventilator. Others, it's a maneuver that does a very short occlusion pressure maneuver, and it measures the drop in pressure and then tells you a value. Now, I will point out that some ventilators give you a positive value, so the number might say 3, and another ventilator might say -3. They're both telling you the same thing. One is telling you the change was 3 centimeters of water. The other one was saying with a negative that it dropped by 3 centimeters of water. It's the same value. Don't get confused if you use multiple ventilators in your institution. Just understand that that value, that P0.1, is demonstrating how much the pressure has dropped in the first 100 milliseconds of the breath. And it's an indication of drive. It's how much effort the patient is making. So in this example on the left, you can see the patient's clearly making a very strong effort, and in the first 100 milliseconds, it would be significantly higher than the patient on the right who's not making a very strong effort, and you can see, again, that P0.1 is very, very small. So the patient on the right is either being over-assisted or over-sedated. If your goal is to get them breathing spontaneous, you need to address that patient. The one on the left is approaching numbers that are considered relatively high. And in fact, normal, healthy breathing patients, 0.5 to 1.5 is normal. During mechanical ventilation, I can tell you that 2 centimeters of water of P0.1 is totally acceptable. Once you get to about 3.5, we have some evidence that 3.5 is excessive. I have not seen anyone argue that a P0.1 higher than 6 should not be considered excessive. Everyone agrees that anything higher than 6, this patient is excessively breathing. We probably should address this and help to give more support to get that drive down. Now, this is a brand new concept. just published 2019, and it's this concept of taking this occlusion pressure, but to actually predict or estimate the PMUS pressure I mentioned that up until now required use of the PAV plus mode or fancy catheters to actually measure this. They predict PMUS and dynamic transpulmonary pressure without using an esophageal catheter. So to do this study and to perform it, they of course had esophageal catheters in all their patients, measured again the PMUS and the dynamic transpulmonary pressure, and then what they do is they do an occlusion maneuver. When you occlude the ventilator and don't allow volume or pressure to change from the ventilator into the lungs, you occlude the airway. When the patient makes an effort, however much it changes actually represents the exact same change that occurs in the chest wall, so in the pleural space. So you know what the pleural space is doing. Now, what's interesting is that when you occlude an airway, the patients almost immediately respond with a stronger effort than what they were using prior to you doing the maneuver. As demonstrated in this graphic, you can see 2 breaths prior. You can see the third tracing down is the esophageal swing. The first 2 look normal and the same. The third one, when they do the occlusion, is greater. So they basically did a number of measurements and determined that to estimate the previous drop, which would help you to determine PMUS and to determine the dynamic transpulmonary pressure, it is a fraction of that large swing during no hold. So by knowing that fraction, you can then estimate these values. And then they have a proposed, and I'm going to show you a calculator on the next screen where you can actually plug in the numbers that you need to get these values. But they propose this diaphragm and lung protective strategy. So I mentioned earlier, lung protection is something we've heard of. Diaphragm protection is what I'm talking about, but can they coexist? And there's probably situations where the diaphragm is potentially being or having injury mechanisms associated with high effort, which could also be leading to lung injury, so both of them are bad. But there may be situations where the diaphragm is actually not working too hard, but we're applying a lot of pressure, which is not safe for the lung. So by over-assisting patients or assisting patients a lot in order to get the diaphragm protected, we may be causing lung injury. So trying to find that balance can be very challenging. So this has a proposed mechanism that you take these measurements, and basically if the PMUS in this example is greater than 13 or 15 centimeters of water, again 10 is the threshold at which they are accurately predicting, and they say once you get to 13 to 15, it's probably excessive, we may want to do something. Or if the dynamic transpulmonary pressure is higher than 15, so it gets to 16 or 17 centimeters of water, we probably should reconsider, monitor this patient more closely because they're probably at risk of either diaphragm or lung injury or both. So if you go online, we developed this online calculator. I developed this online calculator for this paper, which I wasn't directly involved with, but I thought it was a very exciting concept. So I created this online calculator, POCC for the pressure occlusion.coemv.ca. If you go to that URL, you will find this calculator. And in this example, we have a peak pressure while the patient's breathing in pressure support ventilation of 18 centimeters of water, and we have a PEEP level of 8. I do a 1-breath occlusion, and just to give you a little caveat, some ventilators don't allow you to do an expiratory pause during pressure support. It will kick you out of the pause the minute they make an effort. On those ventilators, look for a setting or a respiratory mechanics parameter to measure negative inspiratory force and use that instead. It will work. Anything that will occlude the airway and show you the change in pressure, that's what you need. So some ventilators you can just walk up and do it, others you have to look for a maneuver that will allow you to do it. So when you do that maneuver, you take the change in pressure, and you can see in this example, during the expiratory hold, the baseline pressure was 8, which was my PEEP level. Some patients might have some intrinsic PEEP that you were able to measure when you do a pause, but otherwise it should be close to the PEEP level. 8, and then the patient makes an inspiratory effort that goes down to -2. So I've plugged those values in, and you can see the predicted PMUS on the left is 7, which I mentioned is actually within an acceptable range. On the right, however, is the dynamic transpulmonary pressure, or the predicted dynamic transpulmonary pressure, and you can see it's reached a level of 17 centimeters of water. So we have to now consider, okay, the support the patient's getting is not a lot, but based on their effort, which seems to be okay for the diaphragm, might not be okay for the lung. So we need to find sort of sweet spots to try and determine whether or not we can actually keep the diaphragm in an active, acceptable range of effort and with pressures that are not injurious to the lung. And of course, the patient's inspiratory effort does impact the dynamic transpulmonary pressure. So finding the right setting that gets those into a sweet spot, this is what is being proposed for a future trial. Currently, all this exciting information I'm telling you has not been tested. This diaphragm protective ventilation is a concept that I'm introducing to you as a new and forward-thinking concept that in fact needs to be tested in a proper randomized control trial. But here you are listening to this presentation, you are now aware of what work is being done and where we're thinking we need to actually focus our attention in the future. So in summary, there are various mechanisms that can lead to diaphragm dysfunction. Excessive support, which is simply atrophy from over-assistance. Insufficient support, which gets more complicated because now you start running into potential lung injury issues with concentric loading. Asynchrony, dysynchrony that can have the patient both inspiring too much, but also inspiring after the ventilator then cycles off into exhalation, and you get this eccentric loading, this eccentric contraction. And then this new concept of perhaps PEEP-induced fiber remodeling, that when PEEP is set too high for too long, it may start remodeling the diaphragm, and this could be a possible problem when you then wean your patient's PEEP. Again, conceptual, hasn't been proven yet, but just to keep you thinking. Monitoring techniques are available for a number of ways to estimate inspiratory effort or to measure it properly, and suggested targets exist for monitoring that effort. The best method has not yet been determined, and that's important. Where we have to move forward is these targets should be properly tested in clinical trials to determine if diaphragm protective, first and foremost, is feasible. Can you actually get a patient to go within the ranges that you want comfortably and safely? So, and then does that lead to improved outcomes? These are questions we don't have the answers to yet. And finally, can diaphragm and lung protective ventilation actually coexist? These are the questions that we are looking for answers. Thank you very much for your attention.